Good evening to all of you. And first of all, I will like to congratulate you all for clearing EDIC 1, and now you are for preparing for EDIC Part 2. As today's topic is bit very vast, because I'm going to cover so many points related to burn. What are the various specific questions that has been asked in EDIC 2, or what could be probably going to get asked in EDIC 2 examination related to burn and trauma, although the topic is very big. So, but I have covered few important part that will further sensitize you to read more. So before I should start my presentation, a very small brief CV about me. I'm currently working as an associate professor at AIIMS Patna and serving as a sub-dean examination for this institute. And I have experience of around more than 10 years in critical care medicine. I'm serving as a various editorial board members in like Poland, Hainan, USA, and for BMC series. Currently, I have been given a responsibility for editorial board member for BMC series, in which anesthesiology, critical care, and emergency medicine journals. I'm reviewing few of the journals, and I'm writing editorials for a few of the journals as well. I have around 180 publications, out of which I have just crossed initially 1,000 citations for various papers. So before I should start this presentation, I just want to make you bit more sensitized about the various, because at the end of each topic, I have put few questions, and these questions either would be of multiple choice, only to cope up with the current topic that what I'm going to teach you for today, for basically for EDIC 2 examination, and there are various ATLS various points related to ATLS when I will going to touch the trauma. So before that, I will start the burn part. And here, the important thing is that what is the definition of a burn? Because it's a very specific topic related to EDIC. Why? Because most of the time, the question has been straight away asked from you're charting your fluid resuscitation for the burns, your skin infection, how you're going to treat that is skin infections, and then what are the various classifications of burn, in which class you are going to manage, what is the role of ischiotomy, how you are performing the ischiotomies, and what are the various formulas that has been kept for calculating the total burn surface areas, and what are the various scoring system that is associated with burn, which is not only going to predict the mortality and morbidity, but also how severe your burn is. So before that, burn is an injury to the skin which is inflicted by an external physical insert. And there are basically 4 types of burn. The important thing is that most of the time in the question they used to give that which is of the burn is most common. So it's basically thermal trauma, in which either heat from the liquids like scalds or from solid object like contact burns and flame burn. And they account for the majority of the burn injuries. And apart from that, chemical, electricity, and radiation burn is there. But important thing is there, from 2008 to 2017, the thermal injury accounted for 86% of the admission of the burn centers in the USA, and 41% was caused by the fire or flame, and 35% due to scalds, and 10% due to thermal contact. So my main aim of writing this important epidemiological data to understand that you should not confuse in the exam that which is the most common cause of burn, which is the most common types of burn. So it is a thermal injury, which constitutes around 86% of the admissions. And even the electrical and chemical burn constitutes only 3% of the burn. That's why it is lesser important. Now, coming to the next part, that how these are categorized. So they have been further categorized as a societal or an individual. So if you look for a society, the example may be deprivation because of the overcrowding, because of the use of paraffin in most as a fuel source in most of the societies, very easily access to the chemicals, as well as lack of various safety measures or guidelines or regulation leading to these burns. And if you'll talk at a level of individual level, so now if you'll talk about at an individual level, now again at individual level, the importance lies to smoking, then your substance misuse, either if the patient has epilepsy or some form of peripheral neuropathy or some physical or cognitive impairment. So all these parts can lead to the situations for this burn at an individual level. Now coming to this is very important question, very important for EDIC point of view, that how would you understand the zones of coagulation? So before that, you should understand what is inner zone of coagulation, what is intermediate zone of coagulation, and what is outer zone of hyperemia. So intermediate zone of stasis, and then outer zone of hyperemia, and then your inner zone of coagulation. It means the inner zone, the central portion of the burn wound, undergo maximal and irreversible tissue destruction. Why? Because of the coagulation of the proteins and destruction of the blood vessels. So now this is very important. In the inner zone, the coagulation of the protein, and it is irreversible. Many of the times you will get a MCQ based on the zones, that which zone has a irreversible tissue damage. So it is inner zone of coagulation. What about the intermediate zone of stasis? So in the intermediate zone, there is impaired blood flow due to microcirculatory changes, and it will compromise the nutrient delivery. And then here, the tissue is potentially salvageable, but vulnerable if the situations like hypertension will persist. If you are not going to correct the edema, if you are not going to treat the infection, it is more vulnerable for further tissue damage. And it results in the loss of the tissues, as well as your injury will be further more extensified. That's why it is potentially salvageable, and it can go to either way. And the third part, that is outer zone of hyperemia, basically it's a peripheral area where your perfusion will increase because of the vasodilation in response to various pro-inflammatory mediators, and these tissue will usually recover. So recovery will be occurring in the outer zone, not in the inner zone. The intermediate zone is basically a zone of stasis, which is salvageable. The tissue here is salvageable, and but it is vulnerable if your situations like hypertension, edema, or infection will be there. So for further understanding, it is a central zone, which is a zone of coagulation, which is irreversible. And here the coagulation of the protein and destruction of the tissues will be there. The zone of stasis, in which only impaired blood flow to the vulnerable tissues, it is salvageable. And the zone that is the outer zone, where only because of the peripheral mediators, the vasodilation will be there, and because of that, it is here the tissue repair is possible. So these are the three, and it is known as Morris and Jackson zone of tissue damage. So remember, Morris and Jackson zone of tissue damage, which has been characterized into three parts: the inner, the zone of stasis, and zone of hyperemia. Now coming to the next part, that related to few mediators, because what I thought that again they should ask that how much total body surface area constitutes a major burn. So if it is more than 20%, so if it is more than 20% of TBSA, it can not only cause a major burn, but it can cause a overwhelming multi-organ, like cause a MODS. So for MODS to happen, the TBSA should be more than 20%. So again, this is a one-liner. And apart from that, fluid and heat loss by evaporation. Why it is so? Because of the release of pro-inflammatory mediators. And which mediators will immediately reduce the cardiac output is TNF alpha, IL-1 beta, and IL-6. So these three mediators will reduce the cardiac output. And now the concept of burn shock. So what do you mean by burn shock? Basically, burn shock is there when hypovolemia, because of the evaporation and capillary leak will be there, it will lead to tissue hypoperfusion, and this phenomena is known as burn shock. So in burn shock, there would be a capillary leak because of the evaporation, and because of the hypovolemia, because of the evaporation, hypovolemia will be there, and then capillary leak leading to your tissue hypoperfusion, leading to burn shock. But interesting thing is there, initial F phase is there, in which burn generally lasts for around 48 to 72 hours. Now, this is again a very important question, that what is initial or phase and how long it lasts. So it lasts for 2 to 3 days. Now 2 to 3 days it lasts. And the next part is the flow phase. What is flow phase? Basically, flow phase is a hyperdynamic or hypermetabolic phase. It's a physiological state which happens when a burn injuries has happened. And how the patient will present? The patient will have a tachycardia, the patient will have a increased cardiac output, and often these 2 to 3 times, this may be 2 to 3 times above the baseline. That's why that is very, very important. So here you understand the three concepts about your flame burn, your burn shock, about F phase, and about flow phase. So they can ask about flow phase and F phase and how it is characterized. So mere only knowing these few line facts, you're going to answer your question. Now coming to the, because in the burn stage, there is a stress. There are release of various stress hormones like catecholamines and glucocorticoids, which will cause profound catabolism, loss of muscle mass, and a very rapid negative nitrogen balance. These patients have a very high BMR. So in the later part, I will tell you about the resting energy equivalent, how these calorie requirement is very drastically increased in these patients. How will you monitor whether you will give a total parenteral nutrition to the patient, whether you will give a enteral nutrition to the patient, whether you will opt for post-caloric feeding. So all these things will be discussed later on. Now coming to the several studies, the several studies have suggested, these are very older studies. One was in 1992 and when the 𝐶𝐫 published in 2018, they suggested that the immune dysfunction because of the burn injury will lead to reduced immunoglobulin level, and what it will do. And these neutrophils been affected by impaired chemotaxis, leading to a weaker phagocytic action and reduced bacterial capabilities. Now, the next point is, again, the timeline for the burn and complications. Now, these are the timelines where in the x-axis, you look for the timeline that starts from the 2 months, 2 days, 4 days, 6 days. So that this is the first thing that is very, very important. First 12 days means first 2 weeks, and then weeks, and then months. Now, you see in the x-axis, time from the burn injury is there. So for the first 2 hours, what is very, very important? The fluid shift. The fluid shift, because of the hypovolemia and hemoconcentration, for the first 2 hours, the fluid shifts happen. And when the upper airway burn will be there, if your time of injury from the burn will be around 4 hours. So in 4 hours, you will get an upper airway burn. And if it further persists, if it is around 6 hours from the time of injury, so your dilutional anemia and coagulopathy will start. And if the burn will be around 10 hours duration, then your tracheal injuries, tracheal bronchial injuries will start. And further, then ARDS, then patient will have sepsis, hypermetabolism in a week time or in a month's time. So why it is important? They may ask about these various time frame and related complications, that what are the early complications and what are the late complications when the tracheal bronchial injury will be there and when the dilutional anemia will be there. So dilutional anemia, basically 8 to 10 hours after the burn. Now coming to the next part. Now coming to the parts of the burn. Again, it's a very, very important question because again, in one liner, EDIC 2 part, might be you'll get a case scenario related to your superficial first degree burn injury, and they will test in each part like case-based scenarios whether it is going to involve the upper layer of the skin and epidermis. Yes, in the superficial of first degree burn, the upper layer of the skin and epidermis is going to get affected. And then here the patient will have a erythema, and it is very, very painful. So these two things need to be remembered. And then it blanches on touching. Tissue destruction is very, very limited because healing is very fast. And then these have a rarely blisters and scars are not there in the superficial or first degree injuries. So most of the time you'll get blisters or a scar is present in the superficial or first degree burn injury, but it is rarely seen in the first degree burn injury. Now, what about the partial thickness or second degree burn? So in second degree burn, it extends from dermis and it may be subcategorized into 2 parts like SPT, superficial partial thickness, or DPT, deep partial thickness injuries or burn. So superficial partial thickness have a moist pink appearance and they have profound blisters, and they very generally limited. They have a very limited involvement of dermal regenerative structures. That's why they generally heal. So it is closely related to your superficial thickness burn, and only conservative measurement is required. Whereas deep partial DPT, they are very, very dry. And then now you see for the color, from the pink color, from the pink appearance, it changed to red, cherry red in color, and it is associated with more destruction of the regenerative structures. So they have a very lesser capacity of spontaneous healing, and surgery may be required, and scarring may occur. So here written, surgery may be required. So surgery is mostly required for the third degree burn. That is full thickness burn. So this is the question, that in full thickness burn, always surgical intervention is required, and these are painless because of the destruction of the dermal nerves, and they have white. Now the color changes from pink to cherry red to white, often waxy, and they may have charring. Here the burn extends through the bone or muscles. And that's why it is only important that only the edges of such extensive burns are painful. So you just, in the question, you must see whether they have mentioned about the edges of that burn or edges of that full thickness burn. If edges of the full thickness burn has been written, might be these burns are painful. So only these things need to be remembered. Now, this is a small example of showing that epidermis, dermis, and subcutaneous layer, where in the superficial burn, only epidermis is involved and few part of the dermis is involved. Whereas in superficial dermal burn, the dermis is involved. In the deep dermal part, the most of the, means 2/3 part of the dermis is going to get involved. And in the full thickness burn, apart from the dermis, then subcutaneous tissues and then bone and everything is going to get affected. Now, next part, that how are you going to design those burn, define those burn sites? Because these burn site dictates the systemic sequel, therapeutic intervention, and prognosis. Why? Because it is commonly expressed as a total body surface area, and it does not include the areas of the first degree superficial burn. So for first degree superficial burn, the TBS has been basically not taken up. It is taken up for the partial or deep thickness or your third degree burn, dermal burns. Now, the two charts. First is your Lund and Browder chart. So it is most common chart. One question, it assesses the size of the burn, and then it divides the body into regions, and they have a specific DBSA percentage, which enables the calculation. Now, advantage is that the head, the thigh, and the leg count for varying proportions of the TBSA depending on the age of the patient. And this renders it is more accurate than other tools for particular utility in children whose body proportions changes as they grow. That's why for children, another chart is there. So this is Lund and Browder chart where TBSA is been calculated. Now here all those reasons has been marked. So all those reasons related, it start from head and it ends to the lower limb, like right leg and left leg. Here the right leg and left leg. Then genitalia, buttock. You all know that it's a 13%, then 13% back, 13%, then arm. It is further divided into this part. You need to remember these. It's no point that without remembering it, you will able to solve all those important calculation-based questions. That is important. But here I want to highlight that if the patient is having an age of 0, or if the patient is having an age of 15 or adult, so the A would be here. The A would be one half of the head, that is 9.5 if age 0, and then 4.5 if age is 15 years, and then 3.5 if age is around if the patient achieve his adult age. Similarly, this is B is about one half of the thigh, one half of one thigh. So half of the one half of the thigh is to be calculated for both the reason, right as well as left. This is partial thickness and this is full thickness. Now coming to the next part. Next part is rule of 9 method. Again, rule of 9 method, very easy and to remember. Head from front to back is head is 9. So back total is 18, chest is 18, and right arm is 9, left arm is 9, perineum is 1, right leg is 18, left leg is 18. But in child, head, front and back is 18. And then back is 18. Here, chest is 18, arm is 9, and then 13.5, 13.5, and for perineum, 1.